I would like to thank the Brain Foundation for the opportunity to present my work at this symposium. Today, my presentation will focus on the rat model of exposure to folate receptor antibody and connect the findings to the diagnosis of folate receptor autoimmune disorder in autism and treatment with folinic acid. I'm an inventor in a patent issued in the US for the identification of folate receptor antibody. This test is available in a CLIA certified laboratory. I'm also listed as a consultant in various companies listed here, and these are primarily involved in the developing diagnosis and treatment for autism. And in this presentation, I will also touch upon the use of folinic acid in the treatment of autism. Folate receptor autoimmune disorder was initially identified in neural tube defect pregnancy and subsequently in cerebral folate deficiency syndrome. The characteristic of this disorder is the development of autoantibodies against the folate receptor alpha. The folate receptor alpha is expressed in all epithelial surfaces, highly expressed in the placenta and the embryo, and also in the choroid plexus. So an antibody developed to the folate receptor alpha can bind to this protein and prevent its function. We have identified two types of antibodies. The blocking antibody, this could be an IgG or an IgM. It binds to the active site of the folate receptor where folic acid binds, and as a consequence prevents binding and uptake of methylfolate. The binding antibody does not prevent folate binding to the receptor, but can trigger inflammation and can interfere with folate uptake by virtue of it triggering an immune reaction. These antibodies are prevalent in neural tube defect pregnancy, infertility and subfertility, cerebral folate deficiency syndrome, and autism spectrum disorder. Autism spectrum disorder is a neurodevelopmental disorder characterized by abnormal behavior and social interaction, along with delayed speech and developmental milestones. Current knowledge points to abnormal brain development during fetal life and infancy, contributing to the neurologic deficits. The genetic, metabolic, and environmental factors contributing to autism spectrum disorder remain elusive. While a combination of factors may underlie each clinical phenotype, recently folate receptor autoimmune disorder has emerged as the single most common abnormality in the immediate family and the affected children. Children with cerebral folate deficiency syndrome have low CSF folate, and greater than 80% of these are positive for folate receptor antibodies. Folinic acid treatment restores CSF folate with clinical improvement. Folinic acid treatment was introduced in autism spectrum disorder because 60 to 70% of these children have low CSF folate and are positive for folate receptor antibody. In clinical trials, pharmacologic doses of folinic acid has shown significant efficacy in improving core symptoms of autism. The rat model was developed to understand why and how folate works for the treatment of autism spectrum disorder and cerebral folate deficiency syndrome. To develop this rat model, we initially purified the folate receptor alpha from rat placenta, generated an antiserum to this protein in rabbits, purified the IgG fraction from the immunized rabbits and used that as a source of the antibody. Initially at high doses, when the antibody was administered to rats on gestation day 8, we saw complete resorption of the embryos. However, as we decreased the dose, we could allow the fetuses to develop, and we could see specific abnormalities. Shown here on the top panel is fetus exposed to the antibody, showing malformation of the brain with enlarged ventricles. Similar effect is seen also in another embryo exposed to the antibody. However, if the antibody is specifically removed from the antiserum using affinity chromatography and administered to gestation day 8 rats, the fetal brain develops normally. In addition, if an antibody is administered along with folinic acid, again, the brain develops normally. This indicates that the brain abnormalities that we see in fetuses exposed to the antibody is a very specific effect caused by an antibody to the folate receptor alpha. At low doses of the antibody, pups develop normally, they are carried to term, and they appear to be perfectly normal in physical appearance. However, these pups do have behavioral deficits and show abnormalities in learning, cognition, and memory. Shown here is a active place avoidance task where a shock is administered in a specific area of an arena. You can see normal rats in subsequent trials learn the task and are able to complete it. However, antibody exposed rats cannot do this task even after 6 tries. Now, if dexamethasone or folinic acid or a combination of both is administered during exposure to the antibody, these pups develop normally and are able to complete the task just like normal pups. The effect we see due to the antiserum administration is dose dependent, as shown here at 4 and 12 micrograms. And this effect can be blocked by dexamethasone or folinic acid or a combination of the two. So again, showing that the behavioral deficits caused by exposure to the antibody can be prevented by folinic acid and dexamethasone. Now, antibody administered on gestation day 8 and the embryos evaluated 24 hours later shows extensive accumulation of the antibody as visualized by immunohistochemical analysis to the placenta, the uterine lining, and to the embryo. Higher magnification showing again extensive accumulation of the antibody on the amnion and in the yolk sac. So there is extensive accumulation of the antiserum, specific antibody in the embryo. Shown at the bottom is the embryonic head, again showing accumulation of the antibody throughout the epithelial surfaces, and a closer examination of the ventricles and the choroid plexus shows antibody accumulation both in the choroid plexus as well as the parenchyma of the brain. quantitative analysis of the antibody accumulation in the tissue shows high accumulation of the antibody in the uterus, both at 48 and 72 hours after injection, and also in the placenta with very little antibody accumulation in the embryo compared to the placenta. However, if one looks at the uptake of folate, the effect is significantly higher in the embryo compared to the placenta and the uterus. So high accumulation of antibody in the uterus and the placenta causes significantly decreased accumulation of folate in the embryo compared to the control shown on the bar here. Shown here is visualization of antibody accumulation in the placenta on the left panel here and here. This is a placenta from a normal or non-immune serum injected animal. This is placenta from an antibody injected animal. The brown spots you see are localization of antibody in the placenta. We wanted to check if this antibody accumulation causes local inflammation. So we looked for two markers of inflammation and macrophage activation, CD68 and IL-1 beta, showing normal immunoglobulin injected placenta animal, and here both CD68 and IL-1 beta at very low level expression. However, in the animal that was injected with the folate receptor antibody, you can see increased expression of CD68 and IL-1 beta. A closer view of this process is shown here in this slide, where we looked at normal rabbit IgG injected placenta, marker for CD68, IL-1 beta, a tremendous increase in the expression of both of these markers in the animal injected with the antibody, and decrease in this expression when dexamethasone was administered at the time of antibody injection. Shown on the right is quantitative analysis of the expression of both CD68 and IL-1 beta, and correction of this increased expression when dexamethasone is administered. So dexamethasone administration does one other thing. It increases folate uptake in the embryo, in the yolk sac, and in the placenta. Shown here in blue is the normal non-immune antiserum injected, and in the red, decrease in folate uptake in the presence of antibody. And you can see that throughout the embryo and the yolk sac and placenta, there is a significant decrease in folate uptake. And this decrease can be corrected by dexamethasone. So blocking inflammation seemed to restore folate uptake. So what we have learned from these experiments is that folate transport to the fetus and the brain is affected by the antibody to the folate receptor. This can affect DNA, RNA synthesis, and cell replication. It can also affect synthesis of neurotransmitters. A combination of these deficits will affect brain development and function. Interaction of the folate receptor antibody with folate receptor will trigger immune response mediated inflammation, and this will also affect brain function. Therefore, restoring brain folate with folinic acid and decreasing inflammation with a steroid can restore brain function. So we then asked the question as to how exactly is folate transported from the mother to the fetus. To determine folate transport to the fetus, we looked at uptake and distribution of biotin-tagged folic acid in gestation day 15 rats. So the gestation day 15 rats were injected with 10 micrograms of biotin folic acid, and the animal was sacrificed and the embryos were examined at various time points. The biotin folate accumulation was visualized using avidin biotin complex and peroxidase enzyme. Shown here is a section through the placenta, the yolk sac, and the embryo. In as little as 30 minutes after intraperitoneal injection, you can see significant accumulation of biotin folate in the placenta and in the embryo. In the embryo, now you can see extensive accumulation in the liver, in the heart, and to some extent in the brain portion of the fetus. This accumulation increases significantly by 60 minutes. As you can see here, there is a tremendous increase in the accumulation of biotin folate, both in the placenta, in the heart of the embryo, the heart of the embryo here, the liver, and also in the blood vessels you can see here, and in the brain tissue itself. This can be better visualized in a higher magnification of this region shown here. Again, you can see this brown pigmentation that you see is all accumulation of folate in the uterus, the placenta, the yolk sac, and looking at the embryonic tissue itself, we can see accumulation in the ventricles here around the choroid plexus and in the lining of the ventricle, and also in the brain parenchyma itself. What these studies tell us is that substantial amounts of folate is transported rapidly from the mother to the fetus. An antibody to the folate receptor can block this process. Next, we looked at folate transport to the young brain in postnatal day 23 rats. Rat pups were injected with 5 micrograms of biotin folate, and folate accumulation in the brain was examined histochemically using avidin biotin peroxidase. Shown here, 5 minutes after intraperitoneal injection, biotin folate seems to accumulate in regions of the brain. Shown here is a coronal section of the cerebrum here, and the cerebellum here, showing the appearance of biotin folate in the cerebral white matter tracts. Similarly, you can see in the white matter tracts of the cerebellum also there is appearance of biotin folate in as little as 5 minutes after dose administration, indicating that biotin folate is transported as fast as blood is transported within the body to the brain. So by 15 minutes, you see additional accumulation of biotin folate along the same tracks in the white matter, and similarly in the cerebellum. So by 30 minutes, there is a tremendous increase in accumulation along the white matter tracts in the corpus callosum, and in the cerebellum also in the folds, the white matter tracts, there is tremendous accumulation of biotin folate. And in addition to that, now we see a tremendous increase in biotin folate accumulation in the region, the pons region or the brainstem region below the cerebellum. What this tells us is that there is a tremendous rapid transport of folate in the bloodstream to the brain. Shown here is the effect of folate distribution in the brain. as you can see from the bar graphs here, the first two bars, both in the cortex, the hippocampus, the cerebellum, and the midbrain, that there is pretty much even distribution of folate within these regions. So as far as the brain is concerned, the distribution between the various regions looked at here, the distribution is even. Similarly, the rat given antibody, folate uptake is blocked pretty much to the same extent in the cortex, the hippocampus, cerebellum, and the midbrain. So the blocking effect is also pretty much the same throughout the various regions of the brain. Shown here, diagrammatic, by immunohistochemical analysis, distribution of biotin folate in the brain 24 hours after antibody was given. So in panel A, where non-immune serum was given, you can see extensive distribution along the corpus callosum. This corpus callosum is also involved in behavioral modulation in the two hemispheres. There is extensive biotin folate accumulation in the choroid plexus of the lateral ventricle seen here, in the fimbriae, the internal capsule, and the external capsule. The brain from the animal which received the folate receptor antibody, you can see that there is an overall decrease in the accumulation of biotin folate. Shown in the insert here is actually visualization of the folate receptor antibody, showing antibody accumulation in the choroid plexus of the lateral ventricle, the fourth ventricle, and also in the vasculature of the brain. So in conclusion, exposure to folate receptor antibody during gestation produces severe learning, memory, and cognitive impairment in otherwise normal appearing rats. Antibody exposure produces local inflammation and blocks folate uptake. Once in circulation, folate transport to the placenta and fetal tissue is rapid. Rapid uptake of folate is also observed in the young rat brain. Folinic acid and dexamethasone can prevent the behavioral deficits produced by the antibody. This has clear implication in the treatment and prevention of autism spectrum disorder associated with folate receptor autoimmune disorder. I would like to thank the many people involved in these studies, my laboratory group here. Currently only Jeffrey, my research associate, is with me in the lab. The ongoing research is being done by Natasha, my graduate student, who is looking at transgenerational transmission of the behavioral phenotype and maternal and paternal contribution to this. So this will be an exciting new project going forward. My various international collaborators, Vincent Ray Makers, who initiated the CFD study with us, Jean-Louis Guillain, who did a small clinical trial in the treatment of patients with autism spectrum disorder with folinic acid in France, and is hoping to conduct a larger study. Richard Fry, who's been collaborating with me over many years, he initiated the folinic acid treatment studies in autism spectrum disorder and is currently heading 3 clinical trials, ongoing clinical trials in the use of folinic acid for treating autism spectrum disorder. Frank Middleton is the director of the molecular core facility at SUNY Upstate, and hopefully we will have a greater chance of collaborating with him when we have the current batch of rats with the behavioral transmission available to look at the genome and the epigenome in these rat brains. Thank you for your attention.
Thank you, Ed, for really an enlightening talk and giving us insight into systems that we know affect development, and there are clear, I think, translational opportunities based on your work. Read this to you. How does the human fetus get sensitized to folate receptors so that it develops folate receptor antibodies while in utero? I have read that a child after birth gets sensitized from folate receptors from milk through impaired gut that allows the receptor to reach the bloodstream.
Yes, so two ways exposure to the folate receptor antibodies can occur. One is if the mother is positive, these IgG antibodies from the mother can go across the placenta and affect the brain. The second way, children will develop antibodies after birth. And we have seen this both in the CFD syndrome as well as in the autism spectrum disorder. Here, one of the contributing factors that we have identified is consumption of milk. They seem to appear to have a compromised gut. There is about 5 to 7 micrograms of folate receptor per ml of milk. So it's a lot of folate receptor there. So a compromised gut, exposure of the ingested antigen from the milk appears to trigger an antibody production, which becomes autoimmune subsequently. There is a tremendous molecular mimicry occurring between the human folate receptor as well as the bovine, where it's greater than 95% homology.
Are there other antibody responses beyond that to the folate receptor because of the compromised gut and so the leakiness of antigens from diet?
I think there are other gut disorders such as irritable bowel syndrome or other inflammatory gut disorders where you are likely to see some antigens from the diet you consume triggering immune response.
Thank you, Ed. We have another question that asks simply, why are premature children excluded from all the studies about folinic acid in autism?
Okay. So in fact, if you look at the literature, a couple of years ago, we published a study on preterm birth and the association of folate receptor antibodies. There is a significant association of preterm birth with the folate receptor antibodies. And I believe that the cause many sort of reproductive abnormalities, such as difficulty in conceiving, a miscarriage, and preterm birth are linked to folate receptor autoimmune disorder.